Good afternoon, everybody. I would like to thank everybody for coming and attending our vendor session. I hope the meals are tasty. It sounds like there's a lot of ruckus going on out there, so it must be pretty good. So we'll go ahead and get started. Please continue eating. That's fine. So today we'll have our panelists, and Dr. Sparks will introduce. He'll be our MC for today. Okay, before we get started, just a little quick blurb on who's ScottCare and what we're all about. ScottCare has been a company since the late 80s, early 90s. When we first came out with our product that was designed for home health care market, which allowed monitoring of patients from the hospital to remote locations. But since then, due to CMS reimbursement wasn't there for that, then we stayed with direct telemetry monitoring in the healthcare and cardiac rehab facilities. Our current product, being called VersaCare, is our current offering. VersaCare, hopefully you had a chance to come by our booth. We're there till, I believe, 2 o'clock today. Please stop by if there's anything, if you have any questions or you'd like to know a little bit more about the product. We've been more than happy to answer any questions you may have. One of the main things that we focused on last year and seems to be an idea that has taken off very well is for these hospital organizations, these large organizations that wish to standardize with one common vendor. We have what we call our EIS, our Enterprise Integration Solution, which allows the HL7 interface to be shared among all the locations. So that way it allows data for one EMR vendor that's shared among all these locations to also bring input data from those systems into the VersaCare products, as well as outbound to the EMR systems from VersaCare as well. We've connected with multiple EMR vendors, and this is just to name a few, some of the most common ones, but the HL7 interface that we have, which we call EHR Pipe, has been a product that's been on the market now for almost 10 years. So we do have a lot of installations of our EMR or HL7 interface. And as far as customer support, we believe we have the best customer support out there. Of course, what else would I say? But we tend to take very strong measures and take pride in our product, as well as the service and support that we offer. So hopefully for those that are ScottCare users here in this facility, in this room, can attest to that. As well, we're proud sponsors of the Cardiac and Pulmonary Registry. Okay, so let me go ahead and introduce you to our MC. Dr. Ken Sparks. He's an associate professor at Cleveland State University and the director of Human Performance Laboratory. He received his undergraduate and master's degree from Ball State University and his PhD from Indiana University. Dr. Sparks' area of research includes treatment of cardiovascular disease, patient outcomes and fitness, and obesity in inner city youths. He focuses on exercise as prevention for disease and is currently doing research with DNA looking at genetic variances in Olympic athletes compared to recreational exercisers. He has published over 40 articles and has written 2 books on running. So, Dr. Sparks, the stage is yours.
Thank you. Welcome to everyone to our session here on, I hope that we can put together a nice program for you to enjoy. And, Theo talks about, ScottCare starting back in the late 80s. And I'm the longest, I guess you'd say, associate of ScottCare, because I was a member of ScottCare team when we developed the system back in the 80s before it was ScottCare. And once we developed the system, well, then it became ScottCare, and I've sort of been as a consultant working with further development of that product all these years. So I go back a long ways. There's no one there at ScottCare that started when I started there, but they've been a great group to work with over the years. Moving on, we want to introduce our first speaker. Tammy Garwick is going to talk to us today about what we've learned clinically over the last year in the treatment of heart failure patients. This is something that once we get reimbursement, that we've sort of got our feet wet now, and we want to hear about where we've come from and some of the challenges maybe has come about for that. Tammy is the manager of the Mount Carmel Cardiac and Pulmonary Rehab in Columbus, Ohio. She's been working in the cardiac and pulmonary rehab field for over 20 years, and she has served on the board of the Ohio AACVPR for the past 7 years, and is currently on the AACVPR Membership Affiliate Relations and the Health and Public Policy Committee. So at this time, I'll have Tammy come up, and she's going to talk to you on treatment of heart failure patients.
Thank you. Good afternoon, everyone. Heart failure, where are we now? This is us at Mount Carmel. I have 3 locations across the city. We are building our 4th. They vary in size. At one facility, I am seeing 90 patients per day. That's with a little clause. At another site, I'm seeing 35, so they vary. The clause is we offer a different programming structure. Our program is offered 2 days a week. We offer Monday, Wednesday, or a Tuesday, Thursday program. In February 18th, 2014, CMS came up with the heart failure decision that we've all been waiting for. What does it say? It says that beneficiaries with stable chronic heart failure must meet the following criteria and then are covered for cardiac rehab. That criteria is left ejection fraction, that should say less than or equal to 35%. They must also have the New York Heart Association Class 2 to Class 4 symptoms despite being on optimal medical therapy for at least 6 weeks. They must be stable, not have a recent hospitalization within the last 6 weeks, or a planned hospitalization within the last 6 months for major cardiovascular hospitalization or procedure. You've all heard this, I hope, by now. We're all trying to figure out what it means because CMS is nice enough to put everything gray. So, what have we found out? What does it mean for us? And how many of us are used to calling it heart failure, and then they come out with this technical stuff called HFrEF and HFpEF? So now we're trying to figure out, okay, is he a PEFer or a REFer? So HFrEF is heart failure with reduced ejection fraction, oftentimes classified as less than that 35%. HFpEF is our heart failure with preserved ejection fraction. Those are our diastolic heart failure people. EF still says they're 50%, but we know they have heart failure. Oftentimes, these are your pulmonary hypertension people, your right-sided heart failure. It gets to be a challenge figuring out that HFrEF, HFpEF, and the patients don't know the difference between HFrEF and HFpEF, so it's trying to incorporate that. So our volumes were our fiscal year is July to June. July of 2013 to June of 2014, we had 338 new patients, 5 of which had the heart failure diagnosis. Why 5? Because we didn't start getting payment until February. So February till June, I was able to get 5 in. Then from July of 2014 to June of 2015, we had 596 new patients, 59 had heart failure. We went from a 1.5% of our population being from heart failure to 10%. I don't think we're done. I think that volume is going to continue to go up. So what are some of the things from our experience? kind of jumping forward, I'll jump forward and back a little bit. At Mount Carmel, we have had heart failure cardiac rehab for 4 years, funded by a grant. So we were able to try a couple things with our heart failure patients before we ever started CMS patients. So we thought we'd be all smart and put all our heart failure patients in a 1:30 class time, and we would maximize their education. We could talk about sodium the whole hour. We could talk about edema. We could talk about symptoms. Guess what? The acuity was so stinking high, we were running with our heads cut off. Okay? We had one patient, these guys have high comorbidities. We have a guy running around with diabetes, and his sugar coming in that day was 425. Someone else has gained 7 pounds. We have 3 staff members to 9 patients walking in. Didn't work. Did not work. We also found that group concept to deliver education about sodium, to deliver education about edema, didn't work. We found it's much better to provide individualized education one-on-one, because not everybody was dealing with the same heart failure. And then you have the heart failure that is, are they a 10%er? And are they ready for an LVAD? Or do they have an LVAD? Or are they a 35%er and they don't really have any change in symptoms? So we found the heart failure specific class, no way. No way. So other things that we have learned is we limit the class 4 heart failure patients. This is more under the guidance of my medical director. What we found was the heart failure class 4 patients that we allowed in the program initially spent more time in the hospital than they did in our cardiac rehab program. You have to individualize it when you look at those class 4 heart failure patients, because sometimes them coming to exercise, they really need palliative care more than they need cardiac rehab. And that's hard for those of us in the cardiac rehab program to say, because we want to fix everybody. We want to make everybody better. But for some of those class 4 people, it's not worth it. Both for you, your staff, and for the patient. You actually decrease their quality of life. Policies and procedures. I've talked to tons of people about policies and procedures since heart failure became an allowed diagnosis. What we found was we did not write heart failure specific policies and procedures. Why not? We've always had heart failure. They just had another diagnosis. It was with a valve or bypass. So we didn't all of a sudden get a new population to walk in the door. We've always had them. So we've had to modify a couple things. Now, did we have many LVADs before? No, but we're getting those. So we had to modify our policies and procedures for the LVAD patient who you're now having to take their blood pressure on a Doppler, and you're trying to figure out, doc wants them at 80 systolic, and your policy says 80 systolic means you need to call the squad. So we had to make some modifications with that. Multiple training options. Some other things we've learned. How many people have heard of the HIT and the MIT? HIT is high intensity interval training. MIT is moderate intensity interval training. The literature's out there that it's successful. It's hard for some of these people to implement. Once again, it's individualized based upon the patient. My 82-year-old lady telling her that she's moderate intensity and every 2 minutes she needs to change, she goes, honey, I can't even see that clock. Doesn't work for her. 45-year-old guy who had an MI and his EF's down and he's wanting to get back and he wants to do HIT, there's no problem with him working with HIT. What we also found is the cognitive impairment. How many are seeing a high correlation between your low EFers and their cognitive ability? The blood's not flowing up there. So getting them to keep track of their time and then write down and figure out how many minutes they were here and there and whatever, I'm happy to get them moving. Forget keeping track of the high intensity versus the low intensity. So let me talk a little bit more about our grant. I went to our foundation, asked for some money, was blessed with the money. I work at a Catholic hospital. They bless us a lot. So we started 4 years ago with anybody that has heart failure, systolic or diastolic, because there was no insurance coverage, and we had a high population of heart failure patients and a very successful heart failure clinic. So we had a streamline from our clinic right into us. That streamline, our nurse practitioners, because it is grant funded, I don't have to follow Medicare guidelines. My nurse practitioner could refer that patient into my grant funded program. We provided phase 2-like programming. I couldn't say I was providing cardiac rehab to these people, because that's unethical. There were some modifications, some variations compared to a typical phase 2 program. Some of the things that we found, this is our last grant year, and I wish this was a little bit bigger for you. Our last grant year, we had 45 patients, and on the top box is our MET improvement. So there was a 24.4% increase in METs from pre to post. The blue line is their pre, the red line is their post. So you see a couple blue lines there with no red lines. Couple reasons why. They're still in our program. They have not finished up the grant. Number 2, high dropout rate with heart failure patients. We are having a high dropout rate. It's keeping them motivated, having them have the patience to last a month. Once they're a month, they're good to go, but many of them aren't lasting the 6 weeks. So it's that yet another population for us to deal with. You know, our diabetics tend to be more slugs. Some of our heart failure patients seem to be a little less compliant. So that's what we're noticing. But look at the quality of life scores. This is the Minnesota Living with Heart Failure questionnaire. That's what we use for our quality of life. We had a 30% improvement pre-program to post-program. We choose the Minnesota Living with Heart Failure questionnaire. It is a questionnaire that's across our system. So they use it in the hospital, they use it in the heart failure clinic, and we're using it in cardiac rehab so that we have that consistency. Minnesota Living with Heart Failure questionnaire is also, now that we have that phase 2 coverage, is in with every diagnosed patient with heart failure, regardless if it's their primary or secondary diagnosis. What are some of the challenges we're facing? I like to get my patients started within 2 weeks of discharge. We have a CU in 7 program that when we go see them in the hospital, we're signing them up for a week later. Because of CMS, I can't start these guys for 6 weeks. I'm losing a couple because of the delay in getting them started. And then, if someone's readmitted to the hospital, the clock starts for 6 weeks again. I'm losing track of some of these people. So do I give a script back to the doctor when they go in the hospital? Am I having to wait till they have a follow-up appointment with the doctor? Do I keep their exercise time? Do I put them on hold? How are we working all that? And that's been more of a challenge for us and our process programming than most other things. What we have decided is if a patient is readmitted to the hospital, we pull them out. They no longer have their class time. At 5 weeks after hospitalization, we put it on our calendar. We contact the patient, ask them their status. We then fax the physician for a referral or electronically request another referral. And then we will get the patient started back in the program when there is an opening. They are not guaranteed the spot they had before. And then the other thing that we're having a challenge with is many of our cardiologists are referring our class 3 heart failure patients, but not our class 2. We could really have a strong impact on a lot of these people if we got them in at class 2. So we are in the process of educating our cardiologists how class 2 needs to be a red flag to them to get them into heart failure and to get them into cardiac rehab. One of the nice things that we've used with ScottCare is the reporting system. We've used this both for the patients and for the physicians, and especially the weight tracker. So Scotty here, out of HIPAA, Scotty is my patient. Scotty on session 4 had a weight gain, and session 10 he had a weight gain. Scotty partied on the weekends. Had a couple hot dogs and a beer. So by showing Scott this graph, he was able to see the impact of his lifestyle choices on what it was doing on his weight, and then we provided the education on what it was then doing to his heart and the process through there. And I guess questions are going to wait till a little bit later.
Thank you, Tammy. That was really enlightening. I wasn't sure everything that you were going to talk about because I saw your presentation earlier, and that was really really good. I enjoyed that, and I'm sure everybody else out there did too. And you're probably having some of these same problems that Tammy's having, and we'll save questions and we'll have them after we have Dean's presentation. Okay, next. We're going to be talking about keeping in step with HIPAA compliance, and Dean Diersing is going to be our presenter. And Dean is the supervisor of the Cardiac and Pulmonary Rehabilitation at the University Medical Center in Lubbock, Texas. And he's worked at UMC since 2003. And he received his Bachelor of Science degree in Exercise and Sports Sciences in 2003, and his Master of Science and degree in Clinical Exercise Physiology in 2005, both from Texas Tech. Dean is certified by the American College of Sports Medicine as a registered clinical exercise physiologist, certified exercise physiologist, exercise is medicine certified, level 3, as well as being certified by the AACVPR as a certified cardiac rehabilitation professional. In 2013, he was recognized as a fellow of the AACVPR. He is currently serving on the board of directors for the Texas Association of the Cardiovascular and Pulmonary Rehab, and is a two-time president of the board. He also serves as vice chair of the AACVPR Membership and Affiliate Relations Committee, and will be the chair of this committee at the conclusion of this conference. Additionally, he does a little teaching on the outside. He's an adjunct faculty at Texas Tech University in the Health Sciences Center in the Doctorate of Physical Therapy program, and is an instructor in the Health and Exercise and Sports Science Department at Texas Tech. So at this time, I'm going to bring Dean up, and he's going to talk to us about keeping in step with HIPAA compliance. Dean?
Thank you, sir. I do have a real life and family, but I do all those things in my extra time. Just real briefly, those of y'all that went to the customer appreciation event last night, I thought it was an amazing time, and I want to thank ScottCare for that, so if you guys can help me do that. So it's good to see that you guys didn't just come for the food and you're still here to hear me talk, and I know it was because of this topic. I feel confident it wasn't about the food. But just a little bit about where I'm from. They mentioned I'm from Lubbock, Texas. UMC Health System has been around since 1978. We are a teaching hospital, 456 beds. We partner with Texas Tech University Health Science Center. Our mission is our vision is to serve our patients as the best teaching hospital in the country, and we do that through our mission of service our passion. So that's a little bit about us. This is the sun coming up on the health system in a West Texas morning where it's relatively flat and trees are that's about as tall as they get. But nonetheless, UMC Health System, we are the region's only level 1 trauma center, certified burn unit. We've been recognized through the American Heart Association for stroke care. We have the most advanced neuro treatment within the region. Cancer and Research Center that's hidden behind one of those trees, and it's actually relatively large. Let's see what else. Our cardiology group, we have some of the most advanced stuff within electrophysiology as well as periphery studies. We have the only heart failure specialist that's gone through a fellowship for the region. And so nonetheless, we are trying to be that true leader in care. So that's a little bit about UMC. We do this through our culture, service is our passion. This is really who we are and what we are. And I could bore you with tons of data around that, but we're proud of who we are. We've won many awards. We were recognized this year as the #1 company to work for in Texas through Texas Monthly. Several other awards on there. Press Ganey Awards, we just found out a few weeks ago that we're receiving 2 Press Ganey Awards this year. We're one of only 96 nationally to be recognized for both patient experience and patient safety. Pathway designated, we're on our journey to Magnet, so that's UMC. So the purpose of this presentation is to give you guys an idea of what the capacity of your system is and how you can look at being more secure within your patient information. So I'm going to talk a little bit about our hospital policy as well as national procedures involving HIPAA. My goal was to decrease cost and use less supplies and increase efficiencies as well as storage space, less storage space, and then maximize what the system can really do. So if you guys are real intrigued to read about this stuff, essentially the system does things that are in this document. It's about 17 pages. A lot of what you have to do in your health system is because of documents like these, and our systems have the capacity to do this. So my staff is required to have credentials. I'm sure some of you guys are like this out there. So they have a unique username, password, and this complies with our hospital policies. So this is an easy setup. If you've never done it before, you simply add a person just like you're going to add a new patient. I'm going to look to my right. And the next thing that pops up is that list. And if you've never noticed it before, the staff list is on there. So then you jump into the next screen, and the grayed out area in the background is actually the first thing that pops up. And so you fill that in, and when I entered Shelby, what I did as the administrator was I gave her her username, which is the same username as our health system, and I gave her a password. Shelby1, I'm just making it up, and I'm trying to be HIPAA compliant. So I give her a password. The first time she logs in, she's prompted to change it. So it's truly a secure system. I have no idea what her password is. I do have the capacity to change, or if she gets locked out, I can get her back in. So as an administrator, that's one of the first things you have to do is set somebody up as an administrator. It gives you access to staff, lockout procedures, and we're going to go through some of this. The staff doesn't have access to what I'm going to call the server, so being able to get on and do reports, do backups, things like that. So that was one challenge that we found. My backups we do first thing in the morning, and I just gave one of my staff members administrator rights, and he does the backups every morning. So that was an easy fix in the big picture, but that was the first thing we noticed that, oh no, he can't do backups anymore. So I called my security officer at UMC, and I said, hey, our new system has amazing features, and I want to ask you what we do as a health system, and I want to match that. I want to mirror image that. So I go through this list and I say, how many passwords do we have to use, or when do we get locked out from wrong passwords? And it was 5. And how often do we have to change our password in 90 days? And then is there an auto log out? And all of that stuff existed. And then he followed that with, wait, what system is this? I'm surprised that they have that much. So he was very surprised at what the capacity of the system was, and very kind of eye-opened. You guys have made those phone calls before where they're just answering your questions, but then he kind of toned up whenever I got real deep into it. So that stuff is done early in the game. Don't forget before you enable these features that you have to have an administrator set up, because you'll lock yourself out, okay? I didn't do it, but I was warned, so I'm warning you. So our day-to-day program management. Again, our goal was to increase security, save time, save money through paper, toner, and time. I'm actually doing a Lean Six Sigma project on it, and so long story short, I don't have the data on it, but I hope to by the end of the year to truly show did we save some money relative to this. So staff working the monitor, they have to sign the report with electronic signature. Some of y'all likely use that. We are not integrated within the EMR, so we're still paper-based prior to ScottCare. And so I just wanted to give you that note of we're not set up EMR, so it's a different world for us. I do require staff to log in and log out. Whenever they leave the monitor, they have to log out, and a new staff member logs in. And this is a simple process. Top right of the screen, log in, log out. So they jump in, and essentially this is what shows up, a login screen. They use their username and password and jump right in. So we all know that VersaCare has huge capacities to be our own, and its versatility is one of its game changers in my opinion. And the electronic signature is something that you can put on daily sessions as well as multi-sessions. I'm going to show you information more on the daily session. So one of the things I wanted to do to save time was not print reports, not save reports. We're going to keep everything electronic. And so if you look at the center on the right, and you can see I'm HIPAA compliant right now, everything's whited out. Essentially, we added this electronic signature box. When you click in that box, if you don't have this, it pops up that screen right there. So prepared, reviewed, approved are your options. And then you have a spot for comments, which I'll talk about here in just a minute. So you type in your credentials, and then the next thing that happens is electronic signature shows up, and you truly have dates, times, things like that. We actually, I'll ask you now, I was going to ask you later, how many people in here are JCO hospitals? I would assume the majority. Are there any DNV hospitals? So there's a few of us out there. I'm a DNV hospital. We got dinged a little bit on time stamps, and so this, I'm not even worried about it. I was actually hoping they were coming this week since I was here. That's how it worked out last year in Denver. But nonetheless, this was one thing that I'm excited about, that we have that feature. The other thing we do at our health system is we do peer reviews monthly, which I'm sure a lot of you guys do. You may call them something else, but I went in and reviewed this report and tried to look for compliance and make sure we're documenting things the appropriate way. It gives me the capacity to click reviewed. The thing that it does is it drops that original signature, so we put in here monthly peer review, originally signed by JS John Sides on the date and time. So I had to kind of add that stamp, and all of that ends up residing in that electronic signature square. So that's something that we do at our health system that is another benefit in my opinion. So ScottCare really being that ultimate security, and this is the last kind of piece that I feel like two things. DNV, it's going to help me a ton, and then as well as the security officer saying amazing. But once you set these usernames up, you can view the access history. On the left-hand side, you'll see you have options of searching the data file by date, by the user, so that you could look at what did Dean do in the system. You can also look at the patient file. When DNV came 2 years ago, I wasn't there last year, they actually went to a traditional filing cabinet and said, how do you know who's going in and out of this? And then in comes the FedEx guy. And I'm like, horrible timing. And so I didn't really have an answer, and I didn't answer him. But this, I have no problems now. If they ask me, here you go. Here's my dirty laundry, enjoy it. So it gives you that, and you can see where, actually this was the morning that John found out he didn't have administrative privileges. So he was trying to back up the system and wasn't working. So you get the true audit trail of this system, and that's what our security officer was excited about as well. So in conclusion, I do feel like we have the system with ultimate security, and it's meeting our needs to its capacity. I do feel like we're more secure, we're more clean. I can't say, well, the FedEx guy did just walk through, but he didn't see anything. I think for the most part it's saving us time. I can't put information to this stuff, but I know that we're going to save money even on supplies. And then I had to do storage, offsite storage and all kinds of good stuff. So we're getting there even without the MR world. And this is, I didn't put anybody to sleep, but this is the sun going down at UMC. Are you staying?
Thank you, Dean. Now we're going to open up the questions. Anyone that has one for Tammy or Dean about heart failure or the HIPAA compliance? Yes.
This question is for Tammy. Do you all take patients with IV inotropes in your program for cardiac?
Not yet. That is on the forefront. We're working with the heart failure clinic to establish a process and a procedure for that, but not at this time.
Has that been something you've been approached to take those patients?
We have, but once again, usually if they're on the IV inotropes, they're class 4 heart failure. And so that is a case-by-case basis. Usually those patients are usually denied by my medical director because they are such staff demanding patients. So at this time, we're questioning the safety of those patients. So we're not doing it yet, but that is probably someplace we'll go in the future.
Okay, anyone else? There we go.
I'm Carolyn Beard from Springfield, Missouri. I wanted to ask Tammy, how much money did you get for the grant? Because, you know, sometimes foundations are kind of stingy. I mean, and how much, I mean, do you charge your regular phase 2 what you would charge for Medicare, or do you have like a very reduced rate so you can get more people through? How did you do that?
So it's been a growing process. Our first year we got 2 different grants from a pharmaceutical company as well as a foundation, and they both gave us $10,000 each.
Wow. Which pharmaceutical company?
No way, sister.
No way. Okay. I'll work on that.
That's direct competition.
Yeah.
This last year, they awarded us $146,000. You got to ask. The only thing they can tell you is no. $146,000 allowed us 75 patient visits at 36 visits. We charge the foundation $81 per visit. So yes, it is much less, but our reimbursement is at $100, so it's not significantly less. And we ended up using $115,000 of that $146,000. So before I left, I just submitted for another $100,000 for next year, and we'll see if we got it.
Did you have to do different paperwork or anything, or it really doesn't matter because no one's going to be looking at it because it's not Medicare?
Amen. I did not have to do an ITP on these patients. We chose to do an ITP just for continuity of my staff. I did not have to have physician signature before the patient started, so we could write what we wanted to do because it was a grant-funded program. It is now turned in for our preserved heart failure patients, is who we're serving more now since the others are covered under Medicare. But you get to write your own rules as we go along. We tried to make it more consistent for the staff.
Have you proven that the readmission rate's gone down then?
We have. We, in the 4 years that we have done the program, we have had 2 patients pass away and 3 have been readmitted to the hospital. So we're able to catch much more before readmitted. Now, we've had more readmitted since we got CMS coverage than we did through the grant. And we don't know whether it was the screening process of our heart failure clinic before, and now the physicians are referring for the phase 2. And so our readmission rate is a little higher now that CMS coverage, but we were able to babysit those patients a little bit better and had a very low readmission rate.
Okay, yes.
Steve Woodruff from Australia. I just wanted to echo everything you've said, Tammy, about heart failure programs for patients. We've been fortunate in Australia that we've been providing heart failure cardiac rehab for many, many years, and it works. It does truly work. It keeps patients out of hospital. I could say exactly the same statistics that you just said, that people stay out of hospital for longer periods, and they live longer. They buck the trend with dying within 5 years. So persist and include is my comment.
Okay, anyone else?
Real quick, I want to dovetail a little bit about what Dean has talked about. We also have HIPAA compliance because we have the ScottCare iPads. So when our patients check in, we are not having to yell across the room, 120/70 for Sam, and then somebody sit behind the computer and type it in. We have the iPad, so a staff member is with each patient one-on-one and able to put in some of those other HIPAA type information into the iPads. And that has really helped us, especially with our heart failure patients, because we can track the weight. We can go back and look at their previous weights while on that iPad and keep a little bit better track of symptoms and that type of stuff as well.
Yes.
Thanks. Lynn Hegvik from Kansas City, Kansas. For Dean, when your staff sign in and out of the system, do you have to have all of the patients discharged between classes in order for them to do that, or can they do it fluidly with somebody on the monitor system?
So normally we do our switch at lunch. I haven't found a way to jump out with people on monitor.
Okay, I just have to ask this, although I know you touched on it briefly. I have approached our foundation in the past about grants. They're very nervous about, what you charge cardiac rehab here, and even though you're relabeling it, can you be a little bit more specific how you pulled that off?
Well,
Share a few secrets.
Well, first of all, I went through the grants outside of my foundation and was able to get it from the city foundation and other different foundations at first. How I call it a heart failure exercise program and do not call it a heart failure cardiac rehab program. So these patients are monitored, but not monitored the whole 36 times. These patients do not get to meet with my dietitian in the grant program as many times as they do in my phase 2 program. My heart failure grant patients do not get to meet with my psychologist. So there's enough variations in what we're doing that it is not a phase 2 program. They do not have a physician signature. They do not have physician oversight. So that's how I'm able to differentiate the program enough that it is not phase 2 replicated with a different population.
And if they're so sick that they're qualifying, how are you get the physician release versus a physician referral?
I don't need a physician release. They're not CMS. So I can go through a nurse practitioner. So a nurse practitioner can release them to the program. If they are sick and have to be readmitted, a nurse practitioner can release them back into my program because I don't have to follow CMS rules.
Okay. Anyone else? Okay, we have a few minutes. If you want to stick around and you want to come up and ask some questions on a personal basis, we'll feel free to do so. Thank you for coming.